Hello, good evening, and welcome to tonight's webinar presented or brought to you from the Immunisation Coalition. This is the last infectious disease webinar for the year. If I think back as part of the IC infectious disease webinar series, I have to think back until February, third week of February when we started, eight of them, and that was meningococcal disease webinar, and we progressed throughout the year, tried to sort of um, present each disease area aligned with the season, and we're ending up with the shingles webinar tonight. So welcome everybody. Um, I'm delighted to be moderating tonight's webinar. My name is Andrew Minton. I work for the Immunisation Coalition. I am the CEO. And before I start and introduce our guest speaker tonight, Associate Professor John Litt, I'll just go through some formalities and would like to start with the acknowledgement of country. So I'd like to acknowledge the traditional custodians of the various lands of which we work today and welcome any Aboriginal and Torres Strait Islander peoples that may be participating in this webinar tonight. And also in next week's recorded webinar, which is available for at least 3 months thereafter. So welcome. I'd like to pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands, the animals, and the waters of Australia. Uh, we're very fortunate tonight to have a very well respected presenter, Associate Professor John Litt. He will present for around about 40 minutes, which gives us plenty of time, about 15 minutes for Q&As. If we don't get through all the questions, we will provide a formal answer to those questions in a document that we will provide in about a week's time with a link to the recorded webinar, so we won't miss any questions. As usual, if you can type in your questions below in the Q&A section, that'd be great. I'll be looking for those, but feel free to use the chat function to discuss with other colleagues online. This webinar will be recorded, so as a result, everyone will be on mute. And as I said, it will be available in about a week's time, together with a number of links that we'll provide specifically on our new website and links to the next year's annual scientific meeting and the Coracle long COVID calculator, which John, I think, is going to mention. We'll do our best to finish on time at 7 o'clock, just to respect everyone's time. It is after this will be, dinner time for many of you, and some of you may be still at work, so we don't want to go past 7 o'clock, just to allow you to get home in a reasonable time. So I'd just like to introduce tonight's guest speaker, Associate Professor John Litt. He is from Adelaide. He is a retired academic GP and a public health physician in the discipline of general practice at Flinders University, and was for almost 2 decades the Deputy Chairman of the National Quality Committee of the RACGP. His major clinical and research interests are in prevention and its implementation. And Professor Litt has over 130 peer-reviewed publications, including a number of books and book chapters. And to his credit, he conducted the first Australian National Influenza and Pneumococcal Survey in older adults in 1998, and the first Australian Zoster Attitudes and Beliefs Survey in older persons and GPs in 2009. More recently, he has helped to develop the online COVID risk calculator called Coracle, which is available on our website, which assists the patient decision-making process for COVID vaccination. And the latest iteration from middle of last year of Coracle is on the long COVID version. That's a risk calculator as well. I've been on it this morning just to assess my own risk for long COVID, so it is also available. And if you just type in coracle and long COVID, then that will take you to that application. Um, John has been a member of several national committees, consortia, and scientific advisory committees, including the NHMRC, TAGI, Cancer Australia, and NCEARS. And he was one of the inaugural directors of the ISC, which is the Influenza Special Interest Group, which had a name change to the Immunisation Coalition in 2016. So he was one of the inaugural directors and is currently a member of the Immunisation Coalition Scientific Advisory Committee, which he is a very active member. So a big thank you to Professor Litt for joining us tonight. And without further delay, I'd like to hand over to you, John, to take us through shingles and what's been happening in the last 12 months and what the outlook is perhaps in the next years. Thank you, John.
Thanks, Andrew. I'm just trying to share my screen. Let's see how we go. And thank you for the introduction, Andrew, and for the invitation to present, and welcome everybody. And I know most of you have had a long day, and it's always sort of a push at the end of the day to try and finish on time, and you're all hungry. So hypoglycemia will be a stimulus for us all to try and finish on time. These are my conflicts of interest. I'm not going to karaoke the slide, but largely I actually talk about things that are either in the immunisation handbook or recommended by a TAGI, and particularly focusing on implementation, which they don't spend as much time on. So let's get to the thing there. It'll be in two parts. There's going to be a bit of a review of what we know about shingles, and that's been polished and updated. But there's a few other emerging things in terms of the risk with stroke, the risk of dementia, which I think will generate some interest. And there was a recent Grattan report that really comments about who's getting vaccine coverage in older people, and I'll show you some slides on that, particularly relevant to shingles, and also in terms of some of the frequently answered questions like co-administration and what if you've had the live attenuated vaccine or had shingles. So you would have seen this before, but largely, bottom line is that shingles is going up in incidence, and there are a couple of reasons for that. We have a much larger, older population, and because we've now giving children the varicella vaccine, we're not getting any wild boosting from varicella within the community. So when kids are vaccinated, they don't get varicella, and that was thought to actually increase the level of protection that people got on older age. And so it is increasing. And if we have a look at it, I think this is salutary. And why I put the 60-year-old in is that the PBAC are currently considering lowering the eligibility for the NIP to age 60. They've met in the meeting, but they have not yet decided about that. So that might come sometime in the near future. But if you have a look at the risk, their risk as a 60-year-old patient in your practice, for the rest of their life, their risk of zoster is about 40%. And if you look at 85-year-olds, 1 in 2 of them in their lifetime would have had zoster. And you can see that PHN really rises substantively in older people, so that it's more than doubling between the ages of 60 and 85. And it's particularly problematic, as I will explain later. So in terms of the absolute numbers, that probably doesn't mean as much. People want to know about their individual risk. But what we found, and others have found more recently, is that people don't think they're going to get it. And I think one of the take-home messages is that largely pretty well most of the older population have had varicella, and we've got antibodies showing that. And so that virus is hiding in the dorsal root ganglion, and they are at risk. So it's not like you're going to catch COVID or RSV. You can avoid it by not contacting with people. Wherever you live in the world, if you've had varicella, you've got it sitting in your system. And if your immune system declines for any reasons, and the main reason for that is getting older, then you're going to be at risk. It's the complicated slide. If you look at the text on the left, the older population immunocompromised are at particular risk, and immunocompromised are probably between about 8 and 10% of the GP population, and increasing because they're taking a lot of the biologics and the DMARDs and things there. What people sometimes forget is if you've got a family history, your risk is doubled. And so it's worth asking about that, because for younger people, that they may well truly get an additional benefit because their risk is actually higher. There's a slight increased risk for women, so it's about a 20% increased risk over men. But things like HIV and malignancy, very clearly you've actually got a significantly higher risk, and they can get it several times. We forget that some things like diabetes does have an effect on your immune competence, as well as things like SLE and rheumatoid and whatever. So all of those, can have an increase somewhere between 20 and 50% above the background population. Just to remind people, the pain is pretty intense. And so if we look at acute zoster, it sort of is as bad as acute headache. I can't really comment on labour pain, but it's certainly up there. And post-herpetic neuralgia is certainly near the top end of the scale. And both are really difficult to treat. So I'll comment a bit on that more lately, and particularly about the role of the antivirals might. So we're all familiar with the complications. You can get cutaneous infections, commonly a staph infection in the affected area. The neurological complications are the ones that are problematic, and it's a neurotropic virus. So PHN stands for post-herpetic neuralgia, and I gave you the incidence that earlier, but that rises with age. Stroke is evolving as another potential complication of zoster, and in other parts of the nervous system. So, a transverse myelitis, a cranial nerve palsy, or an ophthalmic one, which can be particularly problematic. And in people who are immunocompromised, then they can actually get that disseminated. So the incidence of zoster is, I've outlined, the chance of getting it again is around 6 to 8%, higher if you're immunocompromised. So you can't sort of say if you've had it once, you're not going to get it again. The risk factors for PHN are a bit different. So age is clearly, which I've shown you in a graph. And with the acute disease, the severity of the pain, the duration of that, and the worse rash all gives you an indication that you're actually getting some sort of dorsal root ganglion inflammation and nerve irritation and destruction, and that is presaging the likelihood of you getting PHN. Interestingly, there doesn't seem to be a risk factor for your gender or whether you're specifically immunocompromised or which dermatome is affected. This is just another slide highlighting that not only does zoster go up in the light blue bars, but the PHN goes up. Effectively, it doubles every decade after the age of 60. So, and given it's one of the two commonest reasons why people go to a pain clinic, you really want to actually try and avoid getting it because it's very difficult to treat, as highlighted in the next couple of slides. So this is a New England Journal paper where they actually followed people with post-herpetic neuralgia. So that's effectively at continuous pain more than 3 months after the original bout of zoster being diagnosed. And it continues, and you can see the green bar is really highlighting that even though there is some reduction, it takes about nearly 3 to 4 years before you actually have that incident. So people are going to have pain for a very long period of time. The challenge for PHN is that the antivirals really don't make a difference. They do reduce the severity of zoster, they reduce the duration, but in the randomized trials, the incidence of PHN is really not affected by taking antivirals, so that you really want to prevent it. And that's where we sort of resort to using a vaccine. And because of the severity of the pain, we've all seen people with significant chronic pain where it spills over into all these other areas, in terms of physical symptoms, the psychological impact in terms of anxiety and depression, the ability to sleep well, and the impact on people's functional abilities. And that all has a kind of social impact. And so, the pain clinics see a lot of these people, and they're not uncommonly seeing someone who's been what I would call feral elderly or ambulatory, ending up in a nursing home or residential care because their quality of life and their functional capacity is actually reducing. So a group of us recently put a summary about ophthalmic zoster. It's probably around 8 to 12%. So it's the second division of the ophthalmic nerve. Sometimes you get a classic Hutchinson sign that we all learned about as medical students. The thing to think about ophthalmic zoster is it's a progressive disease. So it starts on the cornea, and over a period of weeks to months, it sort of enters and progresses to the deeper structures. And so if you don't see much after the initial sort of period, you really do need to follow these people. And I regard it as an ophthalmic emergency that these people actually need to see an ophthalmologist paradoxically, they get topical steroids, but they also get systemic antivirals. Now, you can actually see that the vision loss is quite significant in terms of 10%. Most of that is corneal scarring secondary to the uveitis and damage to the front part of the eye. And antivirals can make some difference. And you can see on the right-hand side of the slide, the live attenuated vaccine actually had a bigger difference. And then finally, the recombinant vaccine is actually getting very good protection against that. So another reason to have the vaccine. This is not something that you want because you do run the risk of going blind. So looking at the risk of stroke, and I've tried to summarize some of the recent systematic reviews here, you can see, the risk goes up, and it's worse probably in the first 3 months, and significantly, about a 22% increase for that. If it's ophthalmic zoster, the increase is actually even higher. So if we have a look at the gender in the bottom graph there, you can see from one of the references that the incidence in males and female is pretty similar. What's perhaps a bit worrying, if you look at the other graph in terms of the age range, the actual incidence of stroke in the 30s and 40s age group is actually higher than those in older adults, which is a little bit of a surprise. So let's look at the next slide. This is one of the earlier big behavioural studies that have been done in the US. So there were two large nurses' health studies and a health professional study, and they actually, with very large numbers, showed that the risk of stroke is not just acute. So if you have a look at the part highlighted in red, and hopefully you can see my cursor, you can see even out to 12 years, there is an increased risk of stroke following the zoster. So that some of those earlier studies that haven't followed people to that period of time, yes, there's an acute risk, but it doesn't actually disappear after the 12-month period. So what can we do about it? We've all heard about Shingrix. It's the only, the recombinant zoster vaccine, which I'll be calling it, is the only vaccine now available for people with, who are at risk of zoster. And its success has been due to two parts. The epitope, which is the part, the immune, they design the vaccine to a part of the virus that is very immunogenic. It's going to trigger your T and B cells to produce that. And they found that the glycoprotein, which is a very common protein on the surface of the zoster varicella virus, was an ideal target. And to get it a turbocharged boost, because older people's immune system doesn't tend to work as well, that's a whole other talk, but for lots of reasons, is that they actually need to try and increase that. And so by adding an adjuvant, and they've added a kind of squalene chemical into the vaccine, which is also in the RSV vaccine and the RSV vaccine, which actually really does make a difference in terms of making the vaccine more effectiveness. And I'll show you some of that data when we get to the actual vaccine effectiveness studies. So this is graphically just showing what it does, and the clinical data is supporting that, is that when you adjuvant it, not only do you get a better initial response, and the key thing for zoster is getting cell-mediated immunity. The antibodies don't have much of an effect. People maintain good levels of antibodies, but a bit like with COVID, you might have antibodies, but it doesn't necessarily mean you're actually not going to get the infection. The other thing is you can see over a period of time is that you get a little bit of waning, but it is significantly above the level of protection provided by a non-adjuvanted vaccine. So that's been a real benefit, which I've talked to people about before, that nearly 30,000 people, double-blind randomized controlled trial. There were two key studies, one over the age of 50 and the other population over the age of 70 to look at particularly at PHN. There were two doses administered about 2 months apart, and they were looking largely, does this prevent people getting herpes zoster and does it prevent PHN? These are the pivotal results, and these are the early results. These are the ones that were originally reported now quite 3.5 years. And you can see you're getting above 90% protection against zoster, and that's unheard of. There are no other vaccines in older people that give you that level of protection. I mean, flu typically gives an adult protection against hospitalization by 30 to 50%. So this is just extraordinary. I'll show you some data that this actually persists over a period of time, but reassuringly, when you have a look at the older population, which is why they included the over 70s, is you can see even people out to the age of 80, you're getting a very high level of degree of protection. So the other endpoints was, does it have an impact on PHN? And you can see in this, it was a very high degree of effectiveness, 91% in those over 50 and 88% over 70. So again, very similar, and age doesn't seem to be having an effect in terms of the vaccine's effectiveness. Other complications like ophthalmic zoster or other neurological sort of elements of that, again, very effective, around 92 to 94%. So this is the data that we're actually looking now that's going out to 11 years. And you can actually see that I'll show it in two parts. I think clinicians are interested in how long ago did the person have the vaccine and what's going to be their protection currently now that they've had it a while ago. And you can see there's a little bit of a decline in the last 2 years of this study, so out to years 9 and 10, dropping down to about 73%. But again, as I mentioned with influenza, this is still, the recombinant zoster vaccine is more effective than that. The other way of portraying this information is to look at what the average protection is. So I've showed you the data on the left-hand side. That's in the primary study. They've now followed people out to 11 years, and over those periods from about year 5.5 up to about 11 years, the overall average effectiveness was around 80%. So, it is a very effective vaccine and it's holding up. And the reassuring things, and I keep asking Tony Cunningham about this, is that the immunogenicity, the CD4 count, which is a reasonable measure of T cells in terms of the degree of protection, if you look at those orange rectangles there, they're all above the the baseline, so that people are maintaining their CD4 counts out to at least 10 years. And Tony's perception is this will probably, in the modelling data that he's had a look at, go out to about 15 years. So the bottom line is at the moment, no one's actually recommending that a person needs a booster, and you're getting at least 10 years in protection. And with fingers crossed, we might even do better than that. So here's some new stuff. In terms of other groups, we often worry about frail people. They may be immunocompromised. They've often got chronic diseases, but they are particularly at risk. Do we protect them? And so there are two papers here. The current paper really looked at different frailty groups and found that their vaccine effectiveness was very similar to those of the people that were not frail. And if you look at this thing on the left-hand side, which was a summary in separate papers of looking at the subgroups, you can see that people with coronary disease or diabetes or asthma and even immunocompromised, they're having pretty good levels of vaccine effectiveness. Given that the subgroups are reasonably small numbers, you can see some of the confidence intervals are quite wide, but largely it's showing this vaccine's not affected by someone's chronic disease status. It's affected a little bit by their immunocompromised status, and I'll give you some data on that shortly to actually provide some further things on it. Now, some interesting stuff. There's been a couple of natural experiments. The largest one's been in Wales, where they've actually analysed it very carefully. But this is a US paper, and it's in a very reputable journal, Nature Medicine, that came out last year, nearly, just over 12 months ago. They stopped offering live attenuated zoster vaccine, which we know as Zostavax, in October 2017. They replaced it with Shingrix. And so they've got two comparison groups here where they looked at people before that date. So that obviously, and they could look at either whether they got any vaccine, but at the time, the only vaccine they could have got was the live attenuated one. And then they looked after that date. And again, they could have got no vaccine or they could have got the recombinant vaccine. And what they've done, and they've reported in an interesting way, is the diagnosis time free of getting dementia. So rather than looking at the absolute incidence, but nearly about 1 in 6 people got half a year additional benefit. Now that's an average effect. So it doesn't give us as much information about the duration of that, but it's very tantalizing as a natural experiment because the date was so, it's providing us with some tantalizing information that there may be some benefit of that. And then, it makes you wonder about what the underlying mechanism is. So antivirals really have an equivocal effect on the risk of stroke. But if you look at the systematic review that looked at it with recombinant vaccine, there was about a 22% reduction. And the table presented there was presented recently at the Cardiology Congress in Madrid. And you can see that that's all cardiovascular events. So it's not just stroke, but it's acute myocardial infarction. is that was about a 21% reduction. So there's consistent evidence that the zoster vaccine particularly is resulting in reduced cardiovascular risk, and that's both myocardial infarction and stroke. If we look at the adverse effects, you can see with the adjuvant, people are going to get a sore arm. And so effectively, that's more common in the older group, so that's the maroon bars. In the blue bars, they're the over 70s. You can see the placebo are in the black and the grey as a contrast. And the grade 3 reactions, which are more severe, are the hatch bars. And reassuringly, they are very uncommon. So these local reactions are lasting only 1 or 2 days. And in terms of the systemic ones, again, with the adjuvant, you can see fatigue, headache, myalgia are common. They're more common in the over 50s than over 70s. And again, it tends to last only 2 or 3 days. This kind of gives you an idea about the impact of that and why we need 2 doses. And so if you look at the bottom right of the screen, when you actually look at only getting 1 dose, your level of protection is going to be 15% absolute less than what you get with 2 doses. And the reassuring thing in that if someone has a severe reaction, that 2/3 of those people will have a lower intensity reaction if they get the second dose. And when we're looking at the timing of this dose, it's recommended between 2 and 6 months after the first dose. If they are immunocompromised, it's usually you can give it the second dose within 1 or 2 months. And so this is the most recent that we've got that came out just the other day. And so zoster does seem to reduce the estimate of trials. When people had antivirals in this systematic review, there was a modest effect on reducing that risk. And so for people that can't get vaccine, I mean, that certainly is worth the vaccine. But when you actually had the recombinant vaccine, then there was a big reduction. So there was a 32% reduction in the incidence of dementia. And we still don't know the mechanism of that. And we need to have a better understanding of that. And we actually need to see in really large randomized control trials with reasonable follow-up what the incidence is. So no one's saying this is an indication for it, but I think this data is available and it's not just coming from Wales and from the US, it's coming from a range of different countries. This is a further one that came out again earlier this year. This was a retrospective cohort study from medical records. And there were 4.5 million records within that. That's an immunocompetent population. The average age was about 62. And you can see that the odds ratio, and there was a reduction in risk of dementia, was about the same as the other systematic review, but this is not a systematic review. So using a different data source, you're getting a very similar estimate of the level of protection. So this is a reminder of the groups. If we look at the under 65s who the NIP are prepared to provide the vaccine to, and you can actually see the ones in the red boxes, they're actually got high risks of getting a zoster. And so it's very much warranted that they actually get offered that. But there are other groups that are also at risk that you need to be considering in your own practice environment. Now, some of those over the age of 65 will just automatically qualify. Under 65, the Commonwealth have actually specified very explicit groups, which I've already highlighted. Tony Cunningham did a good review article on this in terms of the severity of immunocompromise, and that really does give you a chance to do that. I would hope over the period of time that we are very consistent in terms of the NIP, that pretty well everybody on the severe or moderate case would be actually offered that, but we're still waiting for some of those results, and I'll show you those shortly. So this is the results, what we know from immunogenicity, particularly in the groups where we're actually getting an opportunity to give those people the zoster vaccine. And the key thing is the CD4 count. So you can see in this second column that you get pretty good levels, except people with solid tumours who are having chemotherapy. and that does vary a little bit by age. And so that the timing of their treatments and when to give it, a lot of that has now been outlined in the specific immunocompromised chapter, which has been updated in the handbook. So the systematic review in these people, again, a pretty recent study, and they looked at, again, these groups that I talked about. There was a level of protection of about 81%, which is a bit less than the 90% across the groups. And they found that the people with transplants and people who'd had malignance had lower genicity was higher. In terms of, that's the clinical data that we have. So if you have a look in people who've had stem cell transplants, that's what the HSCT stands for. Overall, that's about 90% in the randomized controlled trial, and it does vary. In people that are older, that is slightly less. We only have the overall effectiveness in hematological malignancy. We don't actually have it against PHN or in the various subgroups. I'm going to skip over this because I really want to leave some time for some questions, but this is, and people have access to this. And if you've got particular patients with immunocompromised, and if you have a look at the final column, this is actually looking at a range of those conditions like rheumatoid arthritis, inflammatory bowel disease, ulcerative colitis. So given that these are informing an increasing number of people in your practice population, then often the zoster vaccine is going to be, the recombinant zoster vaccine is going to be recommended. Now, I mean, in MS, the level of effectiveness is a bit lower than other conditions, but clearly something which needs to be discussed. I won't spend too much time on this, but largely is just highlighting, because it's a complex slide, that people who are immunocompromised will have more local effects in terms of pain and soreness, and they'll have more systematic effects in terms of fatigue and others. We don't need, I mean, I can come back to that if people have got interest in that, but that is a warning you'll need to give to these populations. So the NIP has been updated, and they've been clearer about the immunocompromised groups, as we've said to that. And in terms of the level of coverage, unfortunately, we don't tend to record that as well as younger populations. This is largely showing the live attenuated vaccine prior to Shingrix. So that was up to around 40%. This is the latest data available for recombinant vaccine for people who are getting the, and this is just looking at the recombinant vaccine. So, if people would, if they've had the live attenuated vaccine, they're going to get a degree of protection from that, as well, so that you need to add the two graphs together. I'm very pleased to see that South Australia and Tassie are doing pretty well. Some of the other states really need to try and lift their game a little bit. And the Grattan Institute has really highlighted who's getting it. So this is an interesting study. If you look at the bar there, that's the kind of Caucasian population. There are some populations that are getting it more effectively. And so for whatever reason, folk from the Northeast Asia or Southeast Asia see it as a real issue and are getting it. But there are other people, African people, some people from Europe, where the level of uptake of the vaccine is much less. And so I'm just showing this for, think about the mix in your practice population and about who's there, because some groups are going to be less likely to get it offered to them or to take it up without a bit of discussion. This is complicated, but I think it's very interesting to have a look at. It's looking at across all of the vaccines in older people. The Shingrix one is the maroon one, and so that's a red bar. And they've looked at a comparator, and they've looked at education levels. So you can see as education goes up, vaccination goes up, and you can see the Shingrix, which I've got the cursor on. If you look at the rural effect, we know that in people in rural and remote areas, the healthcare is much more Spartan, and the GPs are working flat out to provide that service, and preventive care is often seen as a bit of icing on the cake when you're really pressed for time. And if you actually have a look at the socioeconomic status here, and the index they use, 10 means you're much higher up than the person who's at 1, is that as you go up the socioeconomic gradient, that the level of vaccine coverage gets better. And this in some way is confirmed by the out-of-pocket costs, so that if you don't have much out-of-pocket costs, and that's probably reflecting bulk billing, as a level of coverage, as people are paying more, it's just reflecting they've got a greater ability to pay, and that's affecting that, particularly early on when we've actually had until fairly recently, people having to pay for the Zoster vaccine since before November 2024. A senior GP, more opportunities, and you've probably got chronic disease, so you've got risk factors, and then the kind of regularity of your care in terms of whether you've got a usual doctor, all of that is affecting it. So I don't need to dwell too much on this. You all know how to prepare it. You don't want to leave it out of the fridge too long. And I'll skip over the intentions. I can come back to that. This now really related to the live attenuator, but when I looked at all of the recent data in terms of what predicts it, it really hasn't changed. So it's what makes it reduce your risk of that. You don't think you're going to get it. Well, the answer to that is everyone's got it in their system. They're not needed. Well, again, a variant of that, this will maintain your will maintain your immunity against that. But now the sort of issue of stroke becomes a much more interesting equation with that. And the already good immunity, well, that's really hard to estimate. The natural immunity one is worrying, and a lot of people are saying it's better to get disease, but I've shown you the burden, and that's not the case. If you look at the things below the blue line in terms of what makes a difference, at the end of the day, the most important factor is an advice from you to get it. That will often counter most of the perceived attitudes or concerns that people have about that, and that goes for the practice nurses as much as it does for the GPs. I can come back to these if there's some particular interest. Again, I've shown this before. So they're looking at where things are going. We want to see how well it does at 15 years, because that means we won't have to have a booster. We're looking at the combination of the vaccines with other vaccines, particularly when you've got an adjuvanted vaccine where you're going to get a lot of issues with people getting pain and because of the nature of the ingredients. And we want to really look at some of these immunocompromised groups to see what we can offer them the degrees of protection, and we can span those sort of categories. So in summary, it's common. You're not going to catch it. It's sitting within that. So everybody pretty well is at risk. Hopefully the younger population with sustained immunity after varicella will see less of this, but the primary and secondary rate of failure against the varicella vaccine is up to 20%. And so some of those younger people who had the varicella vaccine may still end up getting varicella and therefore would be at risk from zoster. So zoster complications are not prevented other than the acute severity by antivirals, and they are problematic to treat. Recombinant vaccine is the only vaccine available now. It's available on the NIP for anyone over the age of 65. We've got good data that it's protecting people over the age of 80. We've got better guidance now about the immunocompromised groups, and that's evolving. And the kind of coverage is really plateaued. So your recommendation is really important. And if you had a 1-minute strategy, I would say, I think you should get the vaccine. And if they offer something, a concern, to say, well, what's your main concern, and how can I help with that? And just as a quick plug, the long version of Coracle is out. We've got an article in Press in an international vaccine journal having a look at that. Don't forget that it is still an issue. You've got a 5% chance with the current circulating variants of getting it. We've had over 1 million people in Australia who've had long COVID or have still got it. And the level of coverage in older people, particularly who are very high risk, is declining. The risk of COVID goes up with every bout, and the risk of long COVID goes up with every bout. The median duration is about 4 months. And so how do you prevent it? You don't get COVID if you can do that. So getting a booster will give you a degree of protection against that. By wearing a P2 mask in confined areas will be important, and getting antivirals. And there's the website for that. And as Andrew's highlighted, you can put in all of your age and gender and chronic diseases, and you can get an estimate of your risk, and you can contrast that with not getting a vaccine versus otherwise. I can come back to that, but that's not the main thing there. So I'll stop sharing, and I don't know, hopefully the video, I'll leave my camera off. Hopefully the thing is good enough for further questions.
Thanks, John. Very detailed, very comprehensive overview. So thank you. Spent a lot of time on that. Particularly interested in the complications and the risk factors, but I guess it's all about prevention, right?
Yes.
So your interest is in prevention and implementation.
Yes.
We've got a number of questions here, but I'll probably maybe just kick it off. You can turn your camera on if you like. I was just looking at the NCS 2024 vaccination report, and you had a slide in there. And the Shingrix uptake for NIP eligible patients or individuals has been pretty good. So it's at 34% of, 4.5 million population. 25% of that is with two doses, and 8% is with one dose. So, any thoughts around how we increase the single dose to two doses from a GP perspective? And if
Well,
you
I think the
wait
first thing
more
is
than
to
12
say if
months,
you want to, yeah.
or if you wait for more than 6 months, say it's 9 months or 12 months, what do you do then?
Okay, let's take the second question first. It's quite reasonable to even vaccinate up to 12 months after the first dose. You don't need to start another course. But most GPs have got hot docs. Most of the practices I know are booking in the second appointment. Quite a lot of them are actually having clinics that they're running, and having COVID clinics so they can intersperse that with the Zostavax. So immunocompromised people, you can truncate that interval. So you can go 1 to 2 months after the first dose. But if you book an appointment and you're booking 2 to 6 months after the first one, you can usually find an opportunity for a person to come in and do that convenient, and having immunisation clinics help. To go back, so just repeat your first question again for me.
Um, uh, what would you do as a GP to, I think this is the first question, I can't
Oh, to
remember now.
increase, yeah, sorry.
Yeah, to increase it from one dose to two doses. And the report doesn't say whether or not that single dose is coming from, a GP clinic or whether or not it's coming from
Yeah.
pharmacy. So we don't know.
I think the GP, because you've got a connection with the patient from a clinical perspective, you can make an appointment. And so, I mean, the thing about pharmacy, while yes, it's available and access, but no, the appointment system really gives you a chance to monitor that. I think, and I showed you one slide that the vaccine effectiveness was less after only one dose. And the other thing that's reassuring is that if people do have a bad reaction, that reduces substantively with the second one. So that should reassure people. We can't say that it hurts, therefore it works better. My GP used to say that after I react, because I'm regularly treading on rusty nails or things and getting lots of tetanus shots. And he would say, well, if it hurts, it's working. But that's the problem, because I've had a couple of GPs say, well, the patient got no side effects. And so there they start to question whether the vaccine is effective. And they've actually shown in separate studies that there's no correlation with the amount of pain and swelling and what your immune titers are like.
Thank you. Look, I think I'll just run through the questions.
Okay.
There's some classic questions here, and some of those are covered in the Australian Immunisation Handbook, but I'll read them all out because we have time.
Okay.
If you've never had chicken pox, is it necessary to be vaccinated with Shingrix?
No, but the dilemma will be is that quite a few people would have had it as a mild case. I mean, I had it twice, and the second time round, I had very few spots, but the GP said that's who I saw it was clear. So, and the serology from the Australian population would suggest that 95 to 98% of people above the age of 35 have got antibodies to that. And so you can go on that. I mean, if you really wanted to be pedantic, you could actually measure their antibodies if you wanted to go to the trouble for that. That becomes more of an issue with someone who's immunocompromised. But I would say, you could trust it in a way. But if they've never had varicella, then the vaccine they should get is the varicella vaccine, not the Shingrix vaccine.
Yes. Is there any link between herpes zoster and Parkinson's disease?
Not that I'm aware of. There have been some studies. There was a Dutch study, particularly in women, that people who got recurrent zoster, where they'd ruled out immunocompromise, may have an underlying malignancy, but there haven't been large studies to replicate that. but it could be a marker. If you're getting zoster, it's a marker your immune system's not 100%. So it's worthwhile knowing if someone's got another condition that you might not have thought about, but groups have actually specifically looked at the risk of cancer after that. But no, I'm not aware of any link with Parkinson's disease.
Okay. Do we have any tests that really measure, this is from Jennifer, T cell function
No,
post-immunization?
no. There's a lot of debate. They use a range of different markers, but there's no readily available clinical test where you can measure, are you still protected?
Okay. Is there an increased risk in women due
Yes.
to increased childcare duties? Um,
No, we don't know why women have, it's a 20% increased risk. The family history one is even more, that doubles your risk. But it's about a 20% risk, but it's not really clear what that's due to. So it could be a whole range of things, but I'd have to do some further homework, but I'm not aware.
okay. You have touched upon this. This is from Jacqueline. Do you think we need a booster after the age of 75 years? I mean, Shingrix has only been available for a couple of years, and say you got it at 65, you get at least 10 years protection. By the time you're 75, maybe there's more data out, as Tony Cunningham
So we
said,
need
for
to
about
watch this
15 years.
space because the company will need to present information to ATAGI because that will have a huge impact on the cost effectiveness for that. No country at the moment is offering a boost, is suggesting that we need to offer a booster to Shingrix. Tony Cunningham's data on immunogenicity, which is the best proxy we've got, notwithstanding, as I said, there's no perfect T cell test there, is that you're getting persistent good levels of immunity out to 15 years. We only had about 5 to 6 years with Zostavax. So we don't know, Andrew. I can't say. But I would say if you haven't, so the two other groups, and there may be a question about what if I've had zoster? If you've had acute zoster, you might get a bit of a boost. The ATAGI and the handbook are largely saying you can have it 12 months later after a bout of acute zoster. And if people have had the live attenuated vaccine, well, the government, from a clinical point of view, you could have the Shingrix 12 months after that, but the government have divided that into two groups at the moment. So what they've said is people who paid for their zoster vaccine, the live attenuated, they can get it 12 months after they had that. If they got it on the free one under the NIP, they have to wait 5 years. And the rationale, I mean, it's a little bit about saving money, but you do get protection from the live attenuated vaccine. It's not quite as good as the recombinant zoster vaccine, but but after 5 years, you can then actually get, if you're in the age category, you can get the recombinant zoster vaccine on the NIP. But I'm just saying the government are actually looking seriously at lowering it to the age of 60. That's a PBAC. But once that's done, then they'll have a discussion with GSK about the price and tendering and all the rest of it. So I would say if you're in the age group, get it now. And if you're very worried about getting it, get it. But admittedly, it's a reasonably expensive vaccine. It's going to be $600 for the two, and you're only going to get a modicum back if you've got extras cover in your private health insurance.
Yeah, and I can see why they're thinking about reducing it to 60. I just looked at the NNDSS data this morning. So the 60, over 65 was the predominant highest age group. It's now in 2025, it's the 60 to 64 group. So it looks like Shingrix is actually having quite a dramatic effect if I compare the 65 to 69 group versus last year, it's down 30%, and versus the previous year, it's down 60%. So it does look like that the increase in
Yeah.
vaccination with Shingrix is having an impact, but I see why they might go back to that 60 years and over.
Yeah. And as I said earlier, a thing to remember is after the age of 50,
Mm.
every decade, your risk of actually getting zoster goes up.
Okay. If you have immunoglobulin therapy after every 28 days, is it safe to have the vaccine?
You've got to look at the timing. The best thing for that is look at the immunocompromise chapter in the handbook, and they look at all of those because immunocompromised and all of these various agents have different withholding periods in terms of people on chemotherapy, people having stem cell transplants. They actually give you some guidance about that. So that gets to be too technical to answer it shortly. You need to actually have a look at the immunocompromised chapter and do that to check.
Okay. Another one from Jennifer. You have kind of answered this, but what is the recommended interval between the live and recombinant
12
vaccine?
months.
I guess, yeah, 12 months.
But 12 months,
Yes.
but 5 years if you've
Yes,
got it for free from when you had it.
that's right. So in private script, it's a year, and
Correct.
yeah, exactly. Okay, so it's just a cost thing. Any concern if the second dose of Shingrix was given more than 6 months after, so
No,
12 to
no.
18 months? What you
Look,
suggest?
people, even beyond 12 months, people have said don't give them, don't restart the course again, but try and avoid that. The other thing to do, and I've heard about a couple of cases with pharmacists. The other thing, which doesn't relate to the duration, but it actually relates to how you give it. I've had one colleague who actually got given it subcutaneously by a pharmacist and had a terrible reaction. His whole arm swelled up there. So that is very well understood. It's got to be given intramuscularly for the injection, so that that's across all health providers. Just you need to be really aware of that.
Okay. One here from Bronwyn. It's around what do you recommend the interval is? Do you recommend an interval of 7 days between giving COVID and Shingrix? But I'd also expand upon that to say also flu and maybe pneumococcal. And this could be quite relevant to aged care where all of the residents are eligible for Shingrix. And I know from a previous report that it's around about 19% coverage. So,
Yeah. Yeah, I mean that is always sort of put up in terms of looking at the timing of it. Um, the one thing you've got to worry a little bit about is with adjuvanted vaccines. So if you're going to give the RSV vaccine, now I would tend to separate that, but it's quite clear that you can give things like unadjuvanted vaccines at a lesser time. Now, in terms of a time interval, the challenge with the adjuvanted flu vaccine is that there is a slight diminution of the H3. So that was a presentation to ACIP a couple of years ago. It's not seen with the high dose flu vaccine, but it was seen with the adjuvanted vaccine, which is what is the main one that GPs are using for that. So, and because it's H3, and we know if it's particularly if the vaccine is produced in eggs, there's always a bit of a drift away from the WHO recommendations in terms of matching up the strain, and H3 causes most of the morbidity associated with influenza. So that I personally, as a clinician, would say, look, the opportunity is always an issue, but if you want to get the best protection, I wouldn't be giving the adjuvanted flu vaccine and the zoster vaccine at the same time. But pneumococcal, people under the age of 65 who are getting, an unadjuvanted vaccine, you can co-administer in separate arms. And the
okay.
COVID vaccine, you can have it in the same day in separate arms.
Yeah, okay. If the risk of getting GBS is 1 in 3 million with Shingrix, this is a question that's come through and I'm not across the data. What is the risk of developing GBS following Fluvax?
So the incidence is slightly higher than 1 in 3. I think you said 1 in 3 million.
Yeah,
You're getting 4 or 5 cases, but there's actually been recent evidence that things like influenza and shingle in their own right increase the risk of Guillain-Barré syndrome. And so they've looked at this in the post-monitoring things there. But in terms of Shingrix particularly, the benefit from reducing PHN, which is really problematic, reducing ophthalmic zoster and reducing acute zoster and reducing stroke far out people. So that the background rate from a lot of these vaccines is between about 1 in 3 cases per million people vaccinated.
okay. If a 30-year-old, or in fact any age group, has had shingles, when would you recommend Shingrix? This is a kind of a would you, but it's more of a when. And I was talking to a
Well,
lady today actually who just had,
so
yeah,
if
she was,
they're a healthy adult who are not immunocompromised and don't have a family history and are not particularly worried, I would say you can wait for a period of time, because largely under 50, the TGA registration is for people over the age of 50, or if they've got some degree of immunocompromise. Now, if they've got immunocompromise, some of those groups I've mentioned, you are eligible, and they're looking to look at that in more detail, as I've shown in the kind of future research. So that's a group. But if they're largely not immunocompromised and you're confident about that, then it really gets down to their own concern. But technically, then it's off label, because the group, the data that's been presented by GSK for under 50s is people who are immunocompromised for that group of people. So that
Right.
it technically, I mean, it's going to, in terms of safety, if it's fine in immunocompromised people, it's going to be fine in people that are immunocompetent. But the data that's been presented to the TGA means if you offer it to someone under the age of 50 who's not immunocompromised, then that is technically off label.
Oh, interesting. Okay. So I
But I
was,
mean, we do a lot of things in terms of that. Just because the data isn't there, there's no particular reason. And we're giving it to a lot of people under 50, but some of them have got a degree of immunocompromise, and we're seeing effects of that. But we're not going to expect some wildly different results in people that are immunocompetent. But it technically is, if the company hasn't submitted data to the TGA, then the TGA will not give that approval outside of the specific groups which they have data for.
okay. Thank you. We're on 7. So just maybe one more question. Apologies, I haven't got to a couple of them. Still experiencing very reluctant GPs not wanting to co-administer Shingrix with other vaccines or injections. How do we convince GPs that co-administration is safe?
Well, one of my slides that I didn't actually put up, I had it in the extra slides, is there's very clear data. I don't know if I can go back, and we don't probably have time for that, but
Um,
in the presentation, it actually shows that most of them you can. It's just we've got to be extra cautious about adjuvanted vaccines, and particularly with the influenza one. But I would say you just need to make a case. If you say to the person, I really think you need both of these, now, older populations are coming regular to the GP, so you can just do that, and you can always have a vaccination clinic. So I think sometimes they worry about the hassle factor, but at the end of the day, if you want to maximise the uptake of it, then offer them at a sort of separate time. But there is a slide, and it'll be in my deck, which we didn't get to as an extra slide, that actually summarises the current evidence with the references associated with it.
okay. Just in 30 seconds because my clock has actually stopped at 7 o'clock.
Right.
What are the guidelines time frame? And you've covered this a little bit on antivirals. What's the main benefit? So is that kind of 70?
72 hours really, but if you're immunocompromised, you can extend it out for that. But largely, you really want to get it, the maximum benefit. The sooner you get it, the better. And you want to sort of get on and give it early.
Okay, all right, thank you. It's time to wrap up. So, yeah, thanks, Professor John Litt, for giving your experience and your time. The slides were fantastic, and also thank you for the audience for your engagement and taking the time to join us tonight. So again, the Q&As, we will look at those and we will write formal responses to those, and we will provide those in about a week's time, together with a link with the recorded webinar. So that will occur as I said, in about a week's time. Just want to highlight a couple of things. So we have our 27th ASM next year on the 15th and 16th of February. That'll be in Melbourne. So if you go onto our website, you can register for that, either online or on site if you're a Melburnian. So the agenda is fantastic. We've got some speakers from NCS. We have them from the government. We have international speakers. So it's a fantastic 2-day event. So have a look at that and register, please. Also, our website's been updated, so have a look at that. We'll send that link out together with all the questions and the link to the recording. So we've spent 7 months updating our website. We had to start from scratch. There's a lot of sort of new information in there and helpful things for healthcare professionals, including new news. So do have a look at that. And Yeah, I just want to, since this was our last webinar, I just want to provide a little bit of stats for you on the webinars that we did this year, just on the webinars and some of the events that we did. So we had 5,400 registrations with just over 50% attendance rate. So pretty high. That's across 19 events and excludes some of the podcasts and clinical newsletters and other things that we also communicated out. So we're not a big team. We're only a team of seven, but we managed to cover 27 events throughout the year. So I hope you enjoyed those. So thanks again for joining. Thank you, John, for presenting. You might want to say a few words to the audience before we sign off.
I apologize for the internet. I have looked hard to see why it was, you give me a chance to go and have another look, Andrew. And I hope it isn't too much repeat information, but sometimes it's just worthwhile thinking, in terms of the issues to remind people about it and get it front of house. We need to do a better job in older people. We take kids really seriously, but it's very clear that in older populations, particularly when we're getting effective vaccines, that we need to offer it. It's a way of maintaining health, is what I sort of say to people. So I would say think of a 1 minute strategy, try and work out what the person's most concerned about, and don't underestimate your impact. The evidence is really clear, even when they have some concerns about adverse effects or other things, largely when you recommend it, they will get it. And the odds ratios are, for pneumococcal, it's about 20. For Shingrix, it's about 10. When you adjust for every other factor, if I say to somebody, look, as your GP, I think this is really worthwhile because of X, go out and get it. A lot of people will do it. In our original survey, 85% of people on the basis of that would get it.
Yes, well, we have world-class vaccines, and we just need to identify the risk groups particularly and put the vaccine in the arm. So that's the challenge for everybody.
Yeah,
So
and older people often, there's a real discrimination in a way against older people compared to younger people.
So look, I'll say good night. Stay safe, everyone. Have a nice Christmas and New Year break with family and friends, and I'll see you back in the middle of February with the ASM and the meningococcal disease webinar. So it's good night from me. Thank you.